Hi everybody, and welcome to this latest version of IPC Journal Club, hosted by IPC Partners. We're thrilled to have a special guest today, Jude Robinson, who I'm going to introduce shortly. Just before I kind of run through some housekeeping, the paper that Jude has chosen to review is up on the screen there, a comprehensive qualitative investigation of the factors that affect surgical site infection prevention in cardiac surgery in England using observations and interviews. So just before I introduce Jude, just to kind of recap a little bit about some of the things that we've talked about previously about Journal Club and what we're designed to do if this is your first time. Ideally, we're having somebody to provide an insight into a topical IPC published paper. Typically, it's something that's of interest to them or their research. We really like it to generate a bit of discussion, and hopefully in the Q&A at the end, it'll be a really good opportunity for you to ask Jude questions about the journal, why she chose it, and things relating perhaps to your own practice around surgical site infection. We'd really like it to be used for your own independent study, for you to be enthusiastic as well, and ultimately to try and have a little bit of fun. So it's all light-hearted and informal. And just to say briefly that we've been really overwhelmed with just how popular the Journal Club's been. This is the third one that we've done, and we've had over 700 people register for those 3 events. So we're really happy with the way that things have been running. So before I hand over to Jude, I'm just going to give you a really brief introduction to Jude. Jude is the Infection and Control Senior Nurse for the UK HSA within the National IPC team. Jude's worked within the field of infection prevention for 16 years, where she's held a variety of clinical and academic roles. Jude has just been awarded her PhD, so it's Dr Robinson, where she explored the facilitators and barriers to the effective use of implementation of care bundles for preventing surgical site infections. And I've had the pleasure with working with Jude as part of the Scientific Programme Committee for IPS, which she leads. So without further ado, I'm going to hand you over to Jude. Just a final bit of housekeeping. You've got a chat box and a Q&A box. If you can use the Q&A box for questions, and then we'll have plenty of time for Q&A at the end. Over to you, Jude.
Thank you very much, and thank you very, very much for inviting me to speak today at the Journal Club. I've picked this article mainly because when I was looking through the Journal of Hospital Infection in the July publication, I was looking through that contents page, and the authors really drew their attention to me. So this article is from Professor Judith Tanner and her colleagues, and I followed Judith Tanner's research mainly because it's an interest of mine as well. So I was really keen to know what work she's been doing at the moment. It's very close to the work I've done on my own PhD, so it's a topic that's very close to my own heart. And this study particularly uses some of the research methods that I'd used in my own study. So I feel I'm able to offer a reasonable critique to some of these methods. Just a bit of a disclaimer that any points I've raised are my own opinions, and I would advise you to read the paper yourself before deciding whether you agree with me or not. Please do come to your own conclusions, and as Phil said, this is all about just raising some discussion points and having some fun as we do it. So I have used a critical appraisal checklist as I've critiqued this. I'm not going to talk too much about this. It was just to let you know that I have used a structure to critique it. So we're going to get straight on with looking at the design of the study. So this is a qualitative study, and we know that qualitative is all about that subjective experiences and exploring opinions. It's about exploring the attitudes and usually using methods such as observation and interviews. So there's no numerical data here, no statistics. This is all about those narrative and experiences. So this is perfect for this particular topic. The authors are very clear that they are using ethnography in this study. They say that in the beginning of the study. And what that is really around the study of a culture where the researcher really overtly participates in the daily lives of those being explored. And it's usually over quite an extended period of time. And it's all about exploring and examining those in real time, those shared behaviours, those shared beliefs and those shared customs. So it's really clear that that this study is really, and the design of this study really fits the question that these authors have, and the aim of the study is really suitable. And the study aim is really clear as well. So, and it actually suggests very early on in the study that that what they feel is that some of the findings that we're going to discuss throughout this session, they actually feel would be quite transferable to other surgical specialities. And then we could discuss that later on, and whether we think that we agree on that or not. So moving on to the methods then. So as a typical qualitative study, you would expect to see observations and interviews, and that's exactly what the researchers do here. And it's one of the core questions on the critical appraisal tool about that rationale to the research methods. And it's very common to use two different methods because it's a way of triangulating the data. So again, it just brings a bit of robustness to the data that's been collected. And that's exactly what the researchers have done here. So it really does give it, extra sort of validity. What's really positive about this study is that they use semi-structured interviews. So those of you that have done interviews before, those having a structure to it really does ensure that you're answering your research questions. So it's really positive that they've thought to do this, and they've really thought about those interview questions that they need to answer the questions. And what was really interesting and really quite positive with this particular study is what they've done is they've piloted it. So they've used it a couple of times. They've decided that actually they don't need to make any changes, and then they've been able to use that on the analysis as well. So it's really good that they've kind of piloted that to check that it works. Again, with qualitative research, and actually with any research, ethics is really important, and they've been very transparent that full ethical approval has been sought for this study, which is excellent. I think there's limited detail on the study for those of you that have read it, on actually how did they gain access to the theatres, how did they get that informal consent. However, I do feel that that's possibly more about the word count for the article. You get 3,000 to 5,000 words, and they're certainly going to concentrate on the findings rather than the nitty-gritty of the ethics, when we know that when you say you've got ethical approval, all of those kind of things are usually considered. What I did want to bring to your attention was the researchers. So there was two main researchers that collected the data for this study. One was described as a sociologist, and then the other is a patient researcher. And they spend quite a bit of time talking about why it was so important that they felt that they had a patient researcher to get that patient representation. So we've got two researchers that aren't particularly healthcare background, but then they go on to train these two researchers in etiology of SSIs, about the risk factors for SSIs, interventions for preventing surgical site infections, and despite the authors sort of making it very clear that these aren't health professionals, they've gone out their way to train them, so they've got some idea so they understand a little bit about what they're seeing, and despite them doing that, there's less there about the reflexivity. So actually, what was the impact of their roles on the data that they gave? Again, probably because of the word count. So that's a little bit about the designs and the methods. Just want to come on to the data collection now. So the data has been collected from 4 cardiac centres across England, which is positive that they've used more than one site. So we've got 4 different sites here. Each cardiac site was observed for a week, and it looks that the patients were followed up from when they came into the hospital until they were discharged from the surgical ward that they were on at the time. It looks that there was just one procedure being observed, which is the coronary bypass grafting, which we know is a CABG procedure. And if you look here at the amount of observation hours, it's really quite impressive. So you've got, for the time that they've been in the field, to get sort of 130 hours over 4 weeks is quite incredible, really. And what they've done is they've done that over the 4 sites. They've observed 32 procedures in total. And then they've carried out interviews afterwards. And what they've done is do that over Microsoft Teams. And they had 6 participants in those interviews. And what I've done here is just highlight from the paper what those participants look like. So we had a surgeon, 2 anaesthetists, there was an ODP, 4 surgical care practitioners, an IPC nurse, and then some nurses as well. And I think my only reflection on this part is that I would have liked to have seen a bit of a table breaking down the different sites, to the number of observations, to those that were interviewed, because it's not clear from the patient sort of, I don't know whether 7 nurses were from one site. They probably weren't, but it's just hard to understand that. So it would have been nice to have had a table, and maybe that's elsewhere. So moving on to some of the key findings then. So what I really liked about this, the presentation of the findings, was the way that they themed them into the micro, meso and macro levels affecting SSIs. So I'm going to discuss them as they've been presented in the paper. So the first factors we're going to look at is those micro levels, and the authors very kindly describe what they mean by that as well. So what they say is that from that macro level, they're really focusing on those social interactions of the individuals or small groups. Okay, so that's what we're looking at in these findings. So the first one that they highlight to us is, in their observations, what they've seen is that there's some attributions to interventions that is affecting SSI prevention. And what they do is they provide us with a positive example and then sort of a more negative one, I suppose. So that first positive one, they refer to ChloraPrep, which is a skin preparation. And what they say here is that actually what's observed is ChloraPrep as an example. The end users really love it. It's dead easy to use. It's been designed in a way to make it easy to use, and it's a massive tick. This makes our life loads easier, and everyone really likes it. And then they talk about an example where they refer to face masks, which actually surprised me, if I'm honest. But they talk about face masks and that the fact that nobody likes them in theatre. They're constantly fiddled with, always being touched and adjusted. And I guess the reason why it surprised me that was there, because prior to COVID, theatres would have been using them quite regularly. So it did surprise me that there's still that dislike even in surgery. So moving on to another theme that the authors bring out from the observations and interviews is around evidence, belief and perceived risk. Now, this really interests me because what they really carefully observed in their study is that they've recognised that you've got evidence in one pile, you've got beliefs somewhere else, and these perceived risks elsewhere. And what they've recognised is that there's continuous negotiation between the three. It's almost like almost the way they've said it is that people almost don't realise it's happening, but it's happening almost unintentionally. It's this thing that's constantly happening. So it makes it really complex when you're thinking about the factors that affect SSI prevention. It's really not that simple. Another thing that won't surprise you that came out of the evidence was around the recognised gaps in evidence. So the example that we all know and either love or hate is the betadine and chlorhexidine debate. So that came up as an example that actually there still appears to be some gaps in some of the evidence with some of the guidance. And then another example that they gave was around evidence guidelines sometimes being overruled. And I think this was in more than one setting where they said that they gave an example of hair removal. And they said that actually decisions have been made in more than one of the settings that hair is removed the day before surgery and not on the day. And the rationale around that was that actually they felt that actually it wasn't about the timing, it was more about how it was done. And they felt that it could be done in a safe way the day before. So that was really interesting in terms of that theme around guidelines being overruled sometimes. So on to the next theme. So this theme around power and hierarchy that came out, I think it doesn't surprise you when you talk about surgeons. I think you often have this power hierarchy conversation happening, and this is certainly what's come out of this particular research as well. So they observed a definite defined hierarchy within this particular speciality, which saw surgeons right at the top of the hierarchy ladder, seen as a very powerful professional. And another observation around that was that actually they saw that there was times where other professionals perhaps weren't challenging surgeons, even if there was perhaps a need to. Now, this was very different to the research that I did, where I found that actually there was the challenge up and down the hierarchy ladder. So it does make me wonder whether this is it about surgeons? Is it about organisational culture rather than actually healthcare professionals and status? So that's something we can perhaps challenge ourselves on. Another observation was around consultant surgeons sort of setting the tone to theatre. And I think I'd agree with that just in some of the research that I've done. And they actually comment that there was surgeons from an interview had said that, you know, although they feel accountable for SSRIs, they don't actually feel like they've got the authority to prevent it, which slightly contradicts the power and hierarchy kind of theme, because actually you've got this really powerful professional who's now saying that actually they don't feel like they can make a difference. So that's quite interesting, I think, to hear. And then there was a quote that they gave, the authors select a quote, and it's from a nurse. So I'm just finding it now. And then what they've said is that actually there's this new culture of being nice to each other, and it's actually making challenging behaviour quite difficult. So I think here, you know, we've got to think a little bit about actually we've got civility, we've got challenging behaviour, and we've got to think about how we can make sure that we're balancing that right. Because that was something that actually struck me as quite as I wasn't expecting to kind of hear that from the nurse. So I think it won't surprise you that resource was on there as a theme. No surprise that, you know, there's no equipment, lack of equipment, that, you know, nobody's got enough time, issues with staff training. But actually one of the observations were that actually they observed a lot of cutting corners to try and save time. And obviously that's having a massive impact on SSI prevention. I really liked the fact that the authors chose to sort of highlight the patient empowerment and patient engagement. Although the section's quite small, I would quite like to have seen a bit more discussion on it. However, what they're saying is that we know that giving patient information is key. That's a tick. We've definitely got to do that. And they recognise that patients can initiate change. I think there's so much to patient empowerment and SSI prevention. So it is something I would really like to be further explored. If we've got any budding researchers wanting to have a look at that. I think we then go on to some mesofactors. So these were the mesofactors, were the factors that involve groups and institutions. And there was just one thing that the authors detailed here, and that was around just observing the fact that actually a lot of the time, any interventions that are implemented, it's usually costs that override the clinical recommendation. And that was felt to be not quite how it should be. And then I really like the macro factors that these authors have brought out in this paper. I think in previous studies, and so certainly in some of the work I've done myself, I've kind of seen those macro factors as the wider organisation. However, they've taken it as actual societal, you know, factors. So they talk a lot about COVID pandemic and actually how that's impacting SSI infections, because what we've got at the moment is that patients that should have surgery, they've got to wait because there's a backlog, and actually by the time they get to theatre, they are much sicker, which will impact and increase their risk of a surgical site infection. And also recognising that in the observations and the interviews that what professionals have said is that actually we just don't see our patients now once they've left us. That might be similar for other specialities, but they're being seen out in primary care and they don't actually see their patients. Brexit was mentioned, the war in Ukraine. So in terms of Brexit, what they're saying is that actually that what this has impacted on is the quality of some of our supplies. So we've got, so it's affecting the gloves quality, the gowns, the drapes, and the war in Ukraine, that impact was around the manufacturing of plastics and the supply of chest drains, which of course is quite critical. And then again, probably won't surprise you that some of the macro factors was around the workforce shortages, reducing staff to patient ratios, gaps in expertise, having that high turnover of staff, which was in particular with this speciality and this procedure was felt to be affecting and impacting the CABG patients post-op, and particularly around the wound hygiene. So lots to consider there with the macro findings. So what's really good in research studies is when the researchers actually acknowledge some of the limitations. And that's exactly what these authors do. And one of them is around the timing of the study. So they did it sort of 2021, early 2022. And what they're saying is that actually some of this could have been influenced by post-COVID and Brexit. And maybe that's why that stuff's come out in those macro levels. They do touch on the hierarchy conversation. They know that sometimes that can be affected by gender, but they have not explored that at all in their study. And they're very clear that that was completely out the remit of the study. And I think just some of the limitations that I'd observed, sort of after interrogating some of the data collection, I think when you looked at the participants of the interviews, we saw just one surgeon as an example. So actually we need to think about actually the representation that holds. And actually what I would love to have seen is the same amount of professionals interviewed over each site. So you might have had 4 surgeons, you might have had 4 ODPs, etc. Just to have that equal amount really across the 4 sites. I also, I've said before, I think the data collection, hours is really impressive. But when you think about that definition of ethnography, they've had quite a short space of time really in the field, just 1 week per site. And actually, I challenge you, is it or is it not long enough to uncover those true cultural phenomena? And then I think in terms of the interviews, again, it's not explained, and I presume it's because of the word count of the article, actually why observations and interviews were not done sort of concurrently. I certainly found in some of the work that I did that, it was really helpful to, interview somebody, and that might spur me on to observe something particularly. And maybe they felt they didn't need to do that. And of course, that's absolutely fine. So just very quickly, because I know I've talked way too long, what does this mean for IPC? So this is really, what can we take away from this paper? So I think it certainly helped us to confirm really that, the complexity of factors that affect SSIs. And I think we need to be more vocal across board to ward, micro to macro, so people understand just how difficult and complex this is. Studies suggest that this national context, such as policies, really impacting SSIs. And actually, I think we need to consider and stretch beyond our organisation and even beyond healthcare in terms of those factors that impact SSIs. I think we really need to bring out that encouragement of that internal debate around weighing up evidence, SSI risks, outcomes and costs to help with those implementation and compliance. And then one of the discussion points was around these hard physical barriers. So these are effective hard physical barriers for achieving behavioural compliances. And they use an example where actually we don't want people coming in and out of theatre, so we're just going to lock it, or we're just going to take the stock that we don't want you to use and take it out of the stock rooms. Do we need to consider you being a bit forceful with that, or actually are there better ways to do that? So that's food for thought really. So my overall assessment, when looking back at that critical appraisal tool, is that this is a really robust qualitative piece of research. The results are clearly valid and can help us locally. And my opinion is that these findings can be transferable to other surgical specialities. And I think also just highlights actually that there's so much more qualitative work that we need to do in this SSI prevention space. And I will head back to Phil.
Lovely. Thanks, Jude. It's a really interesting insight, and I really admired how you did the critical appraisal checklist. I think it's not typically the way that I read and analyse papers, but it takes me back to my master's IPC days. Was that helpful for you in terms of bringing out the data and the key points for you?
It was really, yes. And I'm quite methodical, so I have to almost have a checklist to go against. It helps me to, it's how my brain works. But it certainly pulled out things to me that I probably wouldn't have pulled out if I hadn't used that tool. Because I think, I don't know about you, usually when I'm reading a paper, you're doing it sort of, whilst you're doing 3 other things, and you don't really have time to actually really do a deep dive into it. So yes, certainly helped me, and certainly to help me to prepare for this, which I wanted it to be a bit more structured.
Definitely. Well, it came across that way anyway, so thank you. Yeah, thanks very much, Jude. So people are welcome to ask questions. There's a Q&A box at the top there. We've got quite a couple already, Jude, so I'm going to try and navigate through them. There's one question around, obviously, looking at the different staff groups that were interviewed, and you touched upon it, in your limitations, and like how that potentially skews the data. And I think you talked really well about what that means for the paper and our kind of key findings based on, your own analysis. Do you think there's any way that when people are conducting qualitative research, that there is a way that we can ensure that there's that, equal representation across the different staff groups? I think, if I think about my own personal experience, surgeons are probably some of the most difficult people to try and interact with because they're busy, and maybe there's that hierarchy thing that you talked about as well. But I just wonder, is there anything you think that could be done differently to try and make sure that we've got more even representation across different staff groups?
Yeah, that's a really good question. And I think firstly, it's understanding the staff group that you need, because particularly in theatres, so many others that aren't even mentioned in this particular research study. So I think, particularly when I did my research, I had a list that I knew I wanted to speak to, and actually I didn't stop till I got them. and for me it was, and one of the reasons why I kind of queried why they did the interviews remotely, because a lot of the interviews that I did whilst I was doing the observations. So I was able to say, are you free for an hour now, or a little bit later in the day? And I grabbed so many people by not having to make a physical appointment to then go and do the interview that could then be cancelled, etc. So literally I had to have everything in my bag, my recorder, etc., my notes ready. So actually if somebody was saying, yes, actually I could do an interview and I'll be with you in 10 minutes, I was ready. So I think there is about just having that flexibility to work with what's available at the time as well. But surgeons certainly were, when I did my research, I certainly had less surgeons than any other staff group.
Yeah, it's a really good point. And I guess it comes back to resource, doesn't it? About how many people you've got available to ask the questions and also answer them. So
absolutely. And this was an NIHR funded piece of research. Okay, so they would have been hard stops of when they had to stop the data collection, etc. So that might have even put it, they had to have a deadline, and then they only had so much time to get the interviews. There's lots of considerations, I think.
Just some feedback. There's a really nice comment saying, this has raised some really important issues that Anthony's talking about raising at his next IPC meeting, he sits across IPC for 6 different organizations in his ICB. So
amazing.
Good to know it's made a difference. One of my other questions, based on what somebody had written in the chat, was around this idea of how people were ignoring evidence or guidance, and kind of recommendations. And I think, the one around hair removal was really interesting, because I think that's part of NICE and their kind of pre-surgery checklist, isn't it, to reduce SSI? I mean, what if you take the paper aside, really, what's your opinion on people ignoring guidelines and doing something differently?
I would say that evidence is there for a reason. So as a rule, we should try and stick to it. Usually underpinned by a lot of evidence. I think in terms of what they've done in the cardiac field, in the couple of sites that were part of this study, they've gone for expert consensus. You know, they've not just dropped it at the drop of a hat and not considering. What they've done is they've looked at, actually, so why is it important that it happens on the day? And actually, can we mitigate against that by doing it the day before and still do it safely? So I think that has come from an expert consensus to enable to override that guidance, rather than just one person saying, actually, I think we need to change something. So I think there's a process, if you're not going to follow guidance, that you must go through to be sure that it's the right thing to do.
Sure.
But I say my line is, you know, I'm a bit you know, nervous about going against guidance. So you know, my line of thumb is really to do my best to follow what the evidence says.
Yeah, I think I'm the same as you there. I guess in my limited experience, thinking about surgery, you know, particularly trauma and orthopedic, could potentially be quite a chaotic place, couldn't it? So sometimes maybe corners are cut because of just the environment and the situation that people find themselves in. But I definitely agree with you, you know, that evidence is there for a reason, and it's, like you say, been written based on the best available evidence.
Yeah. And I would have thought that those trusts would then have had to gone through the governance to get that approved. So
sure.
there's a structure that you'd go through if you're going to veer away from guidance. There's a structure that you must go through. You get sign off from the board. You know, there's so much to it, isn't there?
Exactly. Yeah, there has to be a process attached to it, doesn't there? This is a really good question that's popped up in the Q&A. Somebody asked about whether or not a focus group would have been a good, you know, methodology for conducting some of the responses. I just wondered what your views were on that.
Yeah, I think, you know, I think focus groups are a really good qualitative method. I think there are some sort of issues with focus groups in terms of, if you've got a group that is dominated by a couple of people, you can sometimes not get everyone's thoughts. So sometimes that's one of the reasons why possibly they're not the first sort of method to choose from. I think possibly that might be the next step, you know, because what Judith Tanner and her colleagues have done have brought out lots of things to challenges, and actually maybe to kind of make some sense of some of that, maybe that's the next step where you would get a focus group together. But I actually think in this instance they've done the right thing. They've looked, they've seen what's happening, and then they've asked people about what they've seen. And I think that's probably the better route to have gone for this one.
Yeah, good response. There's another question here, and I'm going to try and read between the lines, but it's basically, you know, talking, I think, a little bit about what we were talking about in terms of maybe avoiding evidence or recommendations for cutting corners or whatever. And I think it's that the person is asking about this theory around what people are used to doing.
Yeah.
So are they traditionally, they've always done something that way, and that it's very hard to kind of change their behavior. And I think that's something that I can certainly relate to a lot in infection control, that it does come to how you change people's behaviors, particularly things that they've done for a long period of time. So I just wondered if you had a view on, you know, how, when you've got healthcare as an evidence-based profession, and ultimately we are there to try and adhere to the evidence because we think it gives us best practice, how can we change those behaviors to the staff who are actually responsible for making some of those decisions or taking care of the patient? How do you think we can do that?
Yeah, and you know, there is a whole discipline of implementation science which can really help us, and I think in infection control we're not very good at using it. So there, you know, there's certain strategies that are really key to making any implementation work, and any change, you know, changing in behaviours, etc. And you know, first of all, it's, you've got to get people that need to do the change involved at the beginning. You know, you're less likely to get resistance if people feel part of the change. And I think that's a massive sticking point. We often get people higher up in organisations enforcing changes before the front line that are actually involved in it actually hear about it. So, you know, for me, it's like you've got to get people in at the beginning who are going to be affected by the change to begin with. And then, you know, you've got to really have somebody championing it. So actually, you know, and they're the people that are going to be troubleshooting, and the people that are feeling uncomfortable or anxious about a change, you've got somebody to talk to, you've got the questions that can be answered, etc. So I think there's so much in terms of that implementation science body of literature that we can really pull on, that we really need to really be focusing on to make things effective.
Yeah, definitely. And like you say, it is the science, isn't it?
Yeah, it is.
I think
Yeah.
it's the thing that comes back to in my head is, whether or not the resource is there. But ultimately, I think what you said about people championing it, and, you have to really work hard at it, I think is the other key point, isn't it? You have to work really hard to modify people's behaviors and, show them that their change is happening for a reason, that there's a benefit behind it. This is a great question. So somebody's asked about the people doing the observations, and you talked a little bit about their background and qualifications. The question is that would the observations or the findings potentially be different if you had an IPC nurse being responsible for taking those observations?
Yeah, absolutely. And I would say probably yes. Having been an infection control nurse and done similar research myself, there were definitely things that because I knew the field and because I knew the terminology, there were certainly things that I could extrapolate from the data that possibly people that weren't healthcare related wouldn't have done. And actually, I really downplayed that. In my Viva that I had to do, I really downplayed it, and I said, no, I tried to forget this, I tried to forget that. And my examiner said, actually, you've got this wrong, this has really enhanced your research. So I think the question to that is yes. And I say I was slightly just unsure why you would have non-healthcare related or non-IPC or non-surgical folk to do the research if you're then going to try and give them this generic training. I didn't understand that, and I don't know whether again that was down to resource and what they were allowed to use, etc. That would have all been part of the protocol for the funding. But for me, I think it would have probably enhanced it. And actually looking at some of the themes that came out from this study was quite different to my own. And again, possibly, I'm a nurse by background, I'm infection control, and it's definitely would have shaped it, definitely. Yeah,
I thought as much. I will have one more question, and I'm not sure there's an answer to this one, Jude, so it's maybe a point for discussion. But the thing that you said around people being nice to each other, and then their potential to challenge behavior, and potentially linked to the hierarchy piece as well. Obviously we want to be kind and considerate to the people that we work with, and it's part of that team ethos as well, and working collaboratively. But there has to be, doesn't there, an element of where we're not afraid to have difficult conversations and make the right call, depending on what the situation is. I just wondered if you had any thoughts about how you get that balance right.
Yeah, I actually think that this is down to culture of organisations. I don't think it's surgery specific, because I know certainly with my research and then other organisations that I've worked, it can differ just on the organisational stance on that culture. I think, and as an infection control nurse, having to challenge quite a lot throughout my career, you can do it kindly. You don't have to do it in a negative, demeaning way. There's ways to do it which is kind. So I don't think personally that that's an excuse to not challenge. I think we can challenge kindly, and I think in those particular organisations, if you either recognise yourself or not, I would be going to my top people to say, we've got a problem here and we need to look at how we can change the culture of the organisation, because it shouldn't matter what hierarchy we are, we should be able to challenge one another in a safe, kind way. So that civility and challenge, I think we can get the balance right, but it is down to the organisation, I think, to make sure that happens.
Yeah, I completely agree. And I think as part of that culture, you want to ensure that people can speak out no matter, what their position and standing in the organization is, and that it's clearly transparent. And I think what you said then about just challenging in a kind way, you know, is the right way to go forward, isn't it? And ensure that it's a safe space ultimately.
Yeah, absolutely, absolutely.
Yeah, lovely. We're going to call it there because we're coming up to time. So Jude, really thank you very much for coming on and being our first guest, actually. So it was really interesting to hear your perspectives, and thanks for doing such a good job of critiquing the paper and sharing it. There's lots of people clapping and putting their thumbs up. So we've got our next journal club planned for a fortnight's time on Wednesday, the 21st of August. We are working really hard to make sure that we maintain this slot every fortnight. We've gone to 3 weeks this week just because of some timings, but we're doing every 2 weeks. So John will do the next journal club with me facilitating Q&A. We've got now a website as well, so you can see the future schedule for all of our journal clubs. In the next journal club, John is going to be talking about how you can critically analyze good studies. So I don't know if John was inspired by you, Jude, in your critical appraisal, but John is going to be talking about that. So really giving people insight into how you can critically analyze papers as well. Our contact details are there, and like you say, you can subscribe to our mailing list as well, which will not spam your inbox. It will just give you the updates as to when the next journal clubs are. And we're now really looking to invite guests. It's been fantastic to have Jude on today and really share the breadth of infection prevention and knowledge that we want to create within IPC partners and talk about things like surgical site infection. So we're interested to hear from people in the IPC community. If you'd like to analyze a paper and come on and be a guest or be part of a panel, then we'd love to hear from you. We're available on all kinds of social media, Twitter, LinkedIn. Our email address is there as well, or you can contact John and I directly. And yeah, thank you all for attending, and we'll hopefully see you in a fortnight's time. And one final thanks to you, Jude, and wishing you all a very good afternoon. Thank you. Bye.